So, Dr. Bronson, Rachel, fellow co-chairs, ladies and gentlemen, good afternoon. First of all, I would like to thank the Bulletin for associating me with this very important initiative. The Pathogen Project has provided me an interesting forum for exchange, and I have personally learned a lot in the process. Today I shall speak on the Sub-Saharan encounter with the COVID-19 virus, and also on where we stood in terms of preparedness, readiness, and in many ways broke away from the doomsday scenario, sorry for the pun, that was predicated in the early days of the pandemic. Ladies and gentlemen, the coronavirus 2 SARS-CoV-2, first signal in the city of Wuhan, Hubei province, China, was first reported in the African continent in Egypt on February 14, 2020, and by March 11, 2020, the WHO had already declared it to be a global pandemic. Just a few months into the pandemic, COVID-19 had ravaged developed countries with significant case fatality rates in Europe and the United States. Considering the large number of people that live in poor, crowded, and informal settings in Sub-Saharan Africa, the mode of transmission of SARS-CoV-2, the severity of the disease, as well as the existing fragile health systems, it was hypothesized that Africa may be markedly affected by the COVID-19 pandemic, resulting in disastrous consequences with large number of patients overwhelming hospitals and high case fatality rates. There is no doubt that the pandemic has overwhelmed health systems, has taken away scarce resources from fending off concurrent epidemics and managing an already high disease burden. It has been estimated that African continent alone carries 25% of the global disease burden. By June 2020, several countries were already witnessing record infections, but 3 countries with the highest burden were the United States of America, Brazil, Russia, none from Sub-Saharan Africa. At that material time, the African continent was accounting for only 2.6% of global infections, with 2.8% death in 55 countries, which is far below the continent's 17.8% share of global population. 4 African countries, South Africa, Egypt, Morocco, and Algeria, comprise more than 52% of the reported COVID-19 cases in Africa, and only 1 of these countries is located in the Sub-Saharan Africa region. South Africa had been the hardest hit African country with 42%, over 700,000 cases of all confirmed cases, and is ranked 8th in the world. Ladies and gentlemen, the question that everyone had is as follows. Why have the figures remained low in spite of previous predictions and also judging by the preparedness in terms of infrastructure and trained human capital? After all, Africa was fighting its battle with COVID with only about 3 million healthcare workers, and this breaks down to 3 doctors per 10,000 people, compared to nearly 30 for the Americas and more than 40 for Europe, and 1 hospital bed per 1,000 population. Countries like Burkina Faso, Mali, and Niger score lowest in the provision of essential health services. Conflict-affected countries were even less prepared to control and immediately respond to the pandemic. Although the global numbers of SARS-CoV-2 infections increased exponentially since the beginning of the pandemic due to ongoing transmission, the low number of infections and deaths recorded in sub-Saharan African countries have raised suspicion on whether they represent a slow progression of the pandemic in Africa, a lower case fatality rate, or simply lack of testing or reliable data. Empirical analysis have identified reasons as to why African countries have performed better in the face of the pandemic. One of the many, at least got a few, many states implemented strict lockdown measures early and swiftly. They had already created more effective health emergency framework after the experiences with other infectious diseases. African states have active and cooperative societies with high community buy-in for lockdown measures. African countries are young. Only 3% of their populations are over 65. Many Africans live in rural areas, and African countries are less connected to other world regions. Ladies and gentlemen, this is where past experiences and their management, along with the power of institutions, can really change the course of events. The world remembers that between 2014 and 2016, the Ebola virus outbreak ravaged West Africa. Several important lessons were learned. The continent clearly needed stronger surveillance and governance systems and better national pandemic management capacity and capability, in addition to significantly more predictable funding. But to succeed, coordination, communication, and collaboration through the African Union were crucial. Interestingly, countries like Liberia, Sierra Leone, and Guinea employ the same methods and surveillance measures that fended off the Ebola outbreak between 2014 and 2016. They tested extensively, isolated people who tested positive for the coronavirus, and quarantined contact persons. These measures slowed the spread of the virus. The number of reported cases of COVID-19 in these 3 West African countries is 1/12 of that of South Africa. Senegal's success also largely stems from its experience from the Ebola outbreak and also its capacity building with international partners since then. Preparedness training included mock outbreak response exercise, constructing and staffing emergency operation centers. Political will and community buy-in have also greatly helped. In response, with evidence-based policies and transparent risk communication, in daily briefings on the epidemiological situation were essential elements of the government response from the very start. The development of COVID-19 rapid tests costing just $1 made it possible for large-scale testing. The Africa's Center for Disease Control and Prevention, the Africa CDC, has played a pivotal role in coordinating the African Union's continental response during the current pandemic and also released 6 weeks after the first confirmed cases. Because of the vaccine gap, I'm not going to go into all the controversies around this, so the continent had to rely on testing to get ahead of the virus. The Pan-African Partnership to Accelerate COVID-19 Testing was launched by the African Union Commission and Africa CDC as early as April 2020. Thanks to the partnership, the number of countries with testing capacity increased from 2 to 43 in just 3 months. More than 90 million test kits were procured and thousands of lab workers trained. Ladies and gentlemen, the African Union has also partnered with Africa CDC, the United Nations Economic Commission for Africa, and the African Export-Import Bank to create a medical supplies platform. The platform makes it easier for government to locate and purchase vital personal protective equipment by acting as a one-stop shop for procurement, which has improved Africa's bargaining power while supporting African manufacturers. The AUC and the Africa CDC also launched the Trusted Travel Platform to simplify the verification of COVID-19 test results and public documentation for travelers. The African Vaccine Acquisition Trust was established to complement initiatives such as COVAX, a global risk-sharing mechanism for pooled procurement and equitable distribution of COVID-19 vaccines. The trust has secured enough vaccine doses to cover 1/3 of the African population. Regional institutions had an important role to play that went beyond backstopping countries. They helped innovate and adapt a response to regional needs and are close enough to decision makers to secure the required political support. All these were important elements for success. Ladies and gentlemen, on the way forward, these regional institutions will be called upon to guide priorities, coordinate policies and programs, and drive standard setting and disease surveillance, and include inter alia the following: local production of vaccines, therapeutics, and diagnostics to drive down procurement costs and increase response speed, investment in the public health workforce and leadership program, strong high-level partnerships, including between donors and government and the public and private sectors, and with public health institutions, and a greater role for regional organizations in pandemic governance by decentralizing institutions and through regional representatives in key agencies to ensure that the specificities and needs for each region are considered in the planning of central mechanisms such as surveillance systems. Also, a new public health order would require more predictable, long-term funding, not just in building the infrastructure, but also to train nurses, physicians, epidemiologists, and other healthcare workers. While there should be more domestic funding, it will not be sufficient for the needs of low and many lower middle-income countries, at least not in the foreseeable future. It must be bolstered by favorable financing options, supported by strong partnership and investment in pandemic preparedness and response, and backstopped by a fund that can pay for surge expenses as needed. Both the Independent Panel for Pandemic Preparedness and Response and the G20 High-Level Independent Panel Financing and the Global Commons for Pandemic Preparedness and Response recommend a global fund. The G20 panel estimate that it will cost at least $75 billion over the next 5 years to fill gaps in pandemic prevention and preparedness. Ladies and gentlemen, the continuing threat of COVID-19, the effort to rebuild what has been lost over the past year and a half or more, and the task of ensuring that the next pandemic is managed more effectively require a fundamental rethink of our approach to global public health. We need more people-centered health systems that are inclusive. Equity starts by regionalization of health system so that when a crisis hits, regions have the capacity and ability to respond. COVID-19 is a tragedy whose lessons are too significant to ignore. If we take those lessons learned and translate them into a new public health order, we can lessen the effects of future pandemics on our lives and livelihoods in an increasingly globalized world. The COVID-19 pandemic has caused economic declines of unequal magnitude in nearly all of the African countries. Although the direct impact on GDP growth may have been less severe for African economies compared to OECD or Latin American Caribbean economies, in coming years, weak fiscal and external positions and large current account deficits, low levels of economic diversification, high vulnerability to climatic shocks and other natural disasters, and difficulty accessing supply chain may delay African economic recovery. Nonetheless, some positive lessons can be drawn, particularly at the overall macroeconomic recovery. The COVID-19 pandemic has highlighted the structural weaknesses of many African economies, namely the strong dependence on commodity export and knock-on effect of conflicts. The pandemic blatantly showed that Africa cannot outsource the health of its 1.4 billion people to the benevolence of others, or depend on unreliable and highly concentrated value chain outside of the continent. Africa imports over 70% of its pharmaceutical products, and only 1% vaccines are produced locally. The African Development Bank is strongly supporting the Africa 2030 pharmaceutical vision of the African Union with the goal of increasing Africa's share of pharmaceutical production to up to 55% by 2030. The African Development Bank is proposing to invest $3 billion to support pharmaceutical manufacturing in Africa. A new mantra is evolving in the continent, is that investing in health is investing in national security. African leaders need to be reminded on the need to ask for the reallocation of the IMF special drawing rights, the SDRs, to be channeled through the African Development Bank, a prescribed holder of SDRs. It is now becoming increasingly clear how preparedness and response are interconnected processes and have to be articulated and enacted in different settings through formal assemblage as well as informal mobilization, including to mitigate the indirect effects of public health measures. Ladies and gentlemen, there are several other caveats to the wholly positive account of the African experience. The first is that the effects of public health response on economies, livelihoods, food security, and other health conditions have been devastating. The rhetoric coming out of African countries has been, why should I worry about infection when I'm most likely to die of hunger? The negative effect of lockdown restrictions manifested rapidly across the continent, with economic impacts intensified by high reliance of informal livelihoods and markets for food. The public health measures were instituted in the absence of formal social protection systems in most African countries. The extent of the precarity of livelihood was simply not accounted for in the preparedness plan. Politicization of the COVID-19 situation informs the second caveat for consideration of African experience, although this phenomenon is hardly unique to Africa. There have been marked examples of human rights violations, militarizations in some African setting, and indications that political distrust fueled by corruption aided spread of the virus. A third caveat relates to the evident resource limitations. Observations in regional settings in the early days of the COVID-19 suggest that anticipation of the pandemic was not matched by attention to the lack of capacity for response, with a strong suggestion that by one specialist that post-Ebola strengthening had encouraged a false sense of capacity. Major gaps emerged between policy guidelines and resource realities with respect to laboratory and clinical capacity, as well as standard preventing measures. Planning as if for Ebola is likely to have been a factor in the exceptionalist approach in the first period of COVID-19 preparedness, assuming a small number of cases treated by experts in specialist hospitals, rather than a scenario of large numbers requiring mobilization of primary services. Towards the end of 2021, the institutional focus of WHO and Africa CDC shifted discernibly towards vaccine preparedness. So much so that many Africans were saying that the Omicron variant is the vaccine that we never got. Ladies and gentlemen, there have been intensifying concern about vaccine supply and access, as well as challenge to distribution, vaccine hesitancy, vaccine evasion by trial by viral variants have all suggested that reliance on technologies alone might be premature for Africa. Africa, with its 1.4 billion population, will need many different options for even better results on saving lives. I thank you for your attention.